did you learn about complex regional pain syndrome?
Yes.
Right. And in the process in your acquiring knowledge about complex regional pain syndrome, have you learned that complex regional pain syndrome can travel from one extremity to another?
Objection, form, leading.
Yes.
All right, and can you tell us the process by which complex regional pain syndrome in an upper extremity would show up in a lower extremity?
The process is inflammation in nerve roots, in the channels that are rooting up the spinal cord, and in the sprouting of small nerve root connections. It is not terribly common, but when it happens, it's thought to be happening either in the thalamus or more likely in the spinal cord, that small little sprouting of nerve connections are crossing the midline to the other side.
All right. Very good. Let's talk about treatment for this condition. What do we do for it?
Well, the three legs of the stool, as I think of it, are medications, physical therapy, and procedures. I'm a procedure doctor, anesthesiologist, and tend to have a procedure orientation to chronic pain management. But we learn over time, through training and over time, all the other approaches. Neurologists, my wife is a neurologist. Neurologists have a medication approach. Physical therapists, physical medicine and rehab doctors tend to have a physical therapy approach. But patients like this really need a little bit of all of these modalities applied to diminish their symptoms. If someone will get better on medicines alone, their symptoms probably mild, and the physician is very fortunate. But most of the time, patients need a combination of medications and physical therapy and periodic procedures, especially in the moderate and more severe cases.
Right. What type of procedures can be done for this, particularly as it relates to this project?
The procedures are oriented toward decreasing excessive activity in the sympathetic nervous system. And this is a disease of the sympathetic nervous system. And the sympathetic nervous system is that part of the nervous system that is subconscious, out of our control. The autonomic nervous system has two components, sympathetic, parasympathetic. They're in a certain balance and tone. They compete to control our heart rate. They compete to control the tone of our respiratory bronchioles. They compete to control our intestinal function, rapid or slow. And when this process gets going, CRPS, the sympathetic nervous system becomes dysfunctional. And it is usually excessive, but sometimes it swings the other way and becomes diminished. So usually what we're dealing with is excessive sympathetic activity with a cold extremity and an extremity that has a pain syndrome that is described as burning. So our procedures are oriented toward injecting local anesthetics to temporarily diminish function in the sympathetic nervous system. We can do traditional nerve blocks that affect the sympathetic and the somatic nervous system, but then the patient has a numb extremity. The somatic nerves create numbness, like a nerve block for surgery. So we pick spots where the sympathetic nervous system has left the somatic nerve and has created a little ganglia, a little cluster of nerve cells. And we try to, with upper extremity or lower extremity procedures, inject local anesthetic drugs around these nerve plexuses. So specifically, in Ms. Preiser's case, this was a local anesthetic procedure around what's called the stellate ganglion. Stellate means star-shaped.
If I could just interrupt for a second, Doctor. The model you're holding in your hand, that starts at the base of the neck?
This is,
I'm sorry, base of the skull, rather?
This is the back of the skull. and this is the cervical spine. And this ridge back here is essentially right here at the bottom of my collar. So the patient would be looking forward, and the trachea, the windpipe, would be here. So this model shows the somatic nerves, and it doesn't really show the sympathetic nerves. The sympathetic nerves run together with these nerves from the spinal cord out, and then they leave these nerves and synapse right about where my thumb is. The stellate ganglion covers C6, C7, and in some patients goes down to T1, the first thoracic vertebral body. So it's about as big as the tip of my thumb, and it sits right about here against these vertebral bodies. The nerves then leave and rejoin these somatic nerves and run down the extremity. So this provides a point where we can access with needles, inject some local anesthetics, create blockade of the sympathetic nervous system for a period of 6 hours. Now it's only 6 hours, but if we do this periodically over time, we can dampen and reset diminish over time the sympathetic nervous system function. So we did that initially with the patient, and the sympathetic nervous system kept coming back to a high level function. So then plan B for me was to do a second procedure, which is a lesioning procedure. We try to stun the nerve plexus for longer periods of time. And it tends to have 3 to 6 to 12 months of effect. It's a procedure we will call lesioning or ablation of nerve tissue. It doesn't kill the tissue forever. It just stuns it and the nerves recover. Brain cells don't recover, peripheral nerves do recover. So I then did stellate ganglion rhizotomy with a heated needle tip. And I did that on, I believe, 4 occasions, about once a year. She would get reasonably good effect. And in her, I was doing it more to control her blood flow and her sense of coldness to the extremity more than I was her pain. Her pain was more significant early on, but as time went on, it diminished. But the sympathetic nervous system activity and the sense of coldness in the extremity was a persistent aspect of her illness.